Good afternoon. Welcome to the first international webinar organized by Vet and Clinics by Advanced. My name is Alba Martos. I'm the International Veterinarian Manager of Affinity Pet Care. So on behalf of the whole team, we are very happy and excited to start this new season with online sessions. So we will start with the first one today, which is specially designed for the Llus Europe. So we hope that you are plenty of energy and you enjoy this session. First of all, I would like to remind you that you can write your questions during the conference. So at the end, we will discuss with the speaker all the questions and we will answer all of them. So I will not delay any longer and I will present our first speaker. He is Lluís Ferrer. Lluís Ferrer is a teacher of the University of Barcelona. So he's a member of the European and American College of Veterinary Dermatology. And he's also specialized in Leishmaniosis. Good afternoon, Lluís. Thanks to be here.
Hi, Alba. It's my pleasure to be here with you today, and I hope you will enjoy it and the audience will enjoy the lecture.
So, Lluís, we have a lot of questions about Leishmaniosis. So we have prepared the 10 key ones. So the first thing we know is that we have been reading a lot about Leishmaniosis. In a lot of conferences, we speak about this disease. So do you think that it's worth to come back to that issue? Do you think that we have news to share with all the vets?
Oh, yes, Alba. I think there are many new things about this exciting disease. And I also think that we only know one part of this very complex history of Leishmaniasis. And I will try to present you a few new things or to discuss a few topics along the talk. Just to begin with, for instance, we know that the disease is spreading in Europe. If you look at this map was designed about 10 years ago, and the red areas were areas of endemic disease. And the orange areas were areas of the disease being present but not so prevalent. And we know now that the disease is moving toward the north of Europe and the east of Europe. And we have much more detailed information about the hot areas of the disease. We know that we cannot live with maps like this because they are too homogeneous, and Leishmaniosis is a very microendemic disease. We know that there are some spots in each country where the prevalence is very high, and maybe a few kilometers away, there is no disease. And we are beginning to have much more detailed information now. If you go to the EFSA, to the European Food Safety Agency or European Center for Disease Control, there are many maps like this one that you have on the right of the slide with very detailed information about the presence of the different sandflies or the spreading of the disease. So we have a lot of new epidemiologic information. Also, there's a lot of new information about the role of wildlife in the epidemiology of the disease. We have always been thinking of Leishmaniasis as a disease of dogs and humans. Recently, we also start to think of feline Leishmaniasis. But now there are many studies showing that many mammals, many wild mammals, are also host for the disease. Just to give you a few examples, in the very few recent years, we have seen a beautiful paper done in Barcelona showing that 1/3 of the rats living in the city are positive for Leishmania with a PCR. And we know recently the big role played by hares in the transmission of the disease. There is a beautiful paper done in Portugal showing that Egyptian mongoose and other wild carnivores are also hosting the disease. And very exciting, recently has been published that bats, some species of bats, of European bats, also harbor the parasite. So this is a completely new world regarding the epidemiology of the disease. And it's not a surprise because, in fact, if you think on the origins of Leishmania, we know that Leishmania initially was a parasite of the sandflies and of the, let's say, name is mosquitoes. They are not mosquitoes, they are sandflies. And the sandflies transmitted the disease to reptiles. There are many reptiles that are infected with different species of Leishmania. And then finally adapted to many wild mammals. They do not develop a very severe disease, but they harbor the parasite. And there are many species of Leishmania that live in other types of mammals. So we are learning a lot about the epidemiology of the Leishmaniasis. Just to give you an example, Alba.
Thank you, Lluís. It seems surprising that so many mammals can be positive for Leishmaniosis. So the second question I have is that we know that some dogs, when they are infected, some of them, they develop the disease and other ones remain totally asymptomatic. So can you explain us why it happens and which are the main reasons of that?
Yeah, this is connected with the previous question. So many of these mammals do not develop the disease. So they are used to control the infection and they do not develop clinical signs. And this happens also with many dogs. They control perfectly the infection without showing clinical signs. Why is this? We know that after the inoculation of the parasite in the skin by the sandfly, as you see in this beautiful drawing, the promastigotes are attacked by what we call the innate immune response, a very non-specific immune attack to prevent the infection. Basically is phagocytosis by macrophages, enhanced by complement factors, is the attack of neutrophils, the production of reactive oxygen species, and different other mechanisms to kill the parasite. Many species are able to abort, to control the infection at this point, only with a very basic innate immune response. And also some dogs can do that. If this is not enough to control the infection, then the infection persists, and then we have what we call the adaptive immune response. And also many mammals combine an innate immune response, basic attack with neutrophils, macrophages, and other cell types, with a more specific adaptive immune response. In this case, we induce the production of specific T cells that activate macrophages and that controls the infection. What happened with some dogs that you asked me? Some dogs are not able to control the infection, either with the innate immune response or with the adaptive, and they end only producing immunoglobulins. And this is what you see in the lower part of this drawing. These dogs, instead of activating a T helper 1 immune response, produce a T helper 2 immune response, and the consequence of that is the production of many immunoglobulins that are not protective, and the infection progresses and spreads all over the organism. These are some dogs, specifically some breeds of dogs. Most mammals can control the infection with the innate and part of the adaptive immune response. The dog is probably an exception, and we think that this is probably a consequence of the domestication and the inbreeding that we use or that we force to create the breeds of dog probably damage in some way the type of immune response that they can develop against Leishmania, and the consequence is that they suffer from a very severe Leishmaniasis. So this is more or less a summary of why some dogs suffer from severe clinical Leishmaniasis, while most mammals do not.
Okay, so we think that maybe if it's like that, it seems that diagnostic is the key because we have to see if the dogs are positive or not and to control and treat them. So some vets ask or have the doubt about what is the best method to start with, maybe a serological test or maybe PCR or both. What's your experience or what's your opinion?
That's a key point. How can we begin the diagnosis of a case suspected of being a case of Leishmaniasis in a dog, in a patient? And so imagine that many colleagues from East Europe are thinking, what should I do? Should I begin ordering a PCR or just serology? The first thing, talking about molecular techniques, is that there are many. So we refer to them as PCR because it's the most common one, but there are many different techniques. There are PCR techniques like conventional, nested, real-time. There are post-PCR techniques like the combination PCR ELISA. There are gene sequencing techniques, and also these techniques can use different targets and different samples. So the common point of them, or the thing that you have to remember when we talk about molecular techniques, is that these techniques, basically what they do is to detect the presence of Leishmania DNA in a sample. And they are very sensitive and very specific. Imagine that they can detect 0.01 parasite, so just a fragment of a parasite in a sample. So they are amazing. But they are not diagnostic techniques. They only tell you in this sample, be blood or bone marrow or lymph node, there is a small amount of Leishmania DNA. This is not making a diagnosis of Leishmaniasis. Remember that the diagnosis of this disease has to be made by a clinician combining two things, combining a clinical presentation with a proof of an active infection, and also thinking that the clinical signs are the consequence of the infection. So we need three things. We need to have clinical signs, we need to have a proof of the infection, and we need to think that these two facts are connected, and the clinical signs are consequence of the Leishmania infection. Okay, so to make this, the probably best approach is to begin with serology. And this diagram that you have here, this flow chart, was made by the LaceVet group. That's a group of veterinarians interested in and experts in Leishmaniasis. And they propose that when you have a dog with clinical signs of Leishmaniasis, or you suspect that this dog could have Leishmaniasis, the first thing that you can do is a quantitative serology. The first step is doing a serology, a quantitative serology, measuring the presence of antibodies against Leishmania in the serum of this dog. Why? Why serology is preferred for the diagnosis of canine Leishmaniasis? Because it's sensitive and specific, reasonably, it's a good technique, and most important, because the titers correlate very well with the severity of the disease. So if the titer is very high, it's very likely that the clinical signs are due to Leishmaniasis. And this has been investigated and published. And there are several papers. I selected this one by Daniela Proverbio and another group of Italian veterinarians that published in 2014 the good correlation that exists between the titer of antibodies and the clinical score of the dogs. So the more or the higher that the titer is, the more severe that the clinical condition is. And that means that for us as clinicians, serology is very useful because it's telling us two things. One, the dog is infected with Leishmania, and second, the clinical signs, if the titer is high, probably are a consequence of this infection. It's not only an asymptomatic infection, it's that the infection is causing clinical signs. Why PCR techniques are not my first choice in a patient with clinical signs of Leishmaniasis? Well, because we know that especially in endemic areas, many dogs can be positive and be completely asymptomatic or do not show any clinical sign. And therefore, a positive PCR only tells you the dog is infected, but I don't know about these clinical signs. Simply is infected. And for instance, when I'm living in Barcelona, many dogs are positive. So having a positive PCR doesn't mean too much to me. It's true that if you read the literature, you can see, Alba, that the progression of the disease usually is associated with an increase in the parasite load. So if you use a real-time PCR that gives you information about the parasite load, the number of copies of the parasite, a very high parasite load usually is associated with severe clinical signs, but not always. No, not always. There is high variability. For instance, if you use blood is shown to present big changes in the amount of parasites circulating. There are also variability regarding the technique that you use. We have seen how many molecular techniques we have, and also the laboratory doing the technique. Just to give you an example, very recently, this year, 2020, has been published a very interesting article showing that parasitemia in Leishmaniasis changes every day. There's a big, you see on the right, a big change in the number of parasites day after day circulating in the blood. With antibodies, we don't have this issue. Antibodies, for example, we measure usually IgGs. They live for 3 weeks, more than 20 days, so it's pretty stable, the titer of antibodies. It changes very slowly. So if I take a sample today, another sample tomorrow, and one sample the day after tomorrow, the titer of antibodies should be the same. So it's much more reliable. Having said that, Alba, and just to finish this question, the main point is that there is not a technique to diagnose Leishmaniosis. Leishmaniosis is a clinical diagnosis. The clinician should make this diagnosis. And this in evidence-based medicine, there is not a 100% sure diagnosis. We consider the probability of a diagnosis. So imagine this drawing that I showed you. You have a dog with clinical signs. Depending on these clinical signs, the likelihood, the probability of having Leishmaniosis starts to increase. Severe alopecia with a scaling, long nails, weight loss, lymphadenopathy, you start to think, oh, it looks like Leishmaniasis. And then if you accumulate some of these clinical signs, then you reach one point, what it's written here, the threshold to perform test, when you need to do a test for Leishmaniasis. And you will begin with serology. Okay? And then the serology can give you different results. If the result is very high, then the likelihood moves a lot on the right. And then even you can reach the threshold to begin a treatment. It's 100%? Probably not, but you have compatible clinical signs, you have a high positive test, so you decide that with this, you have enough to begin a treatment. In some cases, you will need more pieces to begin the treatment, histopathology or immunohistochemistry or PCR. When you accumulate enough evidence, then you feel that you reach the point to begin a treatment. But the diagnosis under the vision now of evidence-based medicine is not a yes or not, it's more a probability. It's more the probability, the likelihood to have this condition. I don't know if I make this clear to you.
Yes, for sure. It's quite interesting when someone can help us to understand the diagnostic, because sometimes we have so many techniques that it's difficult to see or to understand which one is the best one. And also when we have the results, sometimes even then it's difficult to understand what is the report saying. But I'm asking if you can give us a little bit more details about which is the role of PCR in the diagnostic of Leishmania.
Well, the molecular techniques are useful. In the previous question, I told you that it's not the first technique that we should use when we suspect Leishmaniasis in a dog, but they are useful in some circumstances, in some occasions. For instance, if we want to simply know if a dog is infected, because this is a situation where PCR is very useful. These, let's say, works of these articles that I showed you regarding the investigation of infection in wildlife, they were done using PCR technique, for instance, in rats or in bats or in other animals. They are also useful in some cases in the diagnosis of clinical cases of Leishmaniasis. And also, we'll see that can be used for a more precise identification of the species of Leishmania. Let's begin with the first one. So, if we want to do an epidemiological study, we, in many cases, use PCR because it's very sensitive. So, if we want to know if dogs living in one European country are infected by Leishmania or not, together with serology, we can use PCR, and it's much more sensitive. These positive dogs probably are healthy, are clinically healthy, but they can be infected. If we want to investigate the rabbits in Spain regarding infection, a very good technique is to take samples of the different tissues and do a PCR. So for that, it's very useful. We also use this technique to evaluate blood donors to be sure that they are not infected, to investigate breeders because there is vertical transmission of Leishmania. And also if you want to be sure that one dog moving from South Europe to Scandinavia, it's negative, you can do serology and you can do PCR to be sure that there is no infection in this animal. Let me show you. Also, the molecular techniques, the PCR, can be of interest in the diagnosis of Leishmaniasis in some specific cases, not in all cases. For most cases, we have quantitative serology, but for some specific situations, they can be very useful. For instance, let me begin with the first point in the slide, a seronegative or low positive dog. We know that most dogs with clinical signs of Leishmaniasis, they have a high titer. They are easy to catch. You have a dog that looks like Leishmaniasis, you do a quantitative serology, it's positive, over. I can begin to treat them. But in some cases like this boy, you have a dog that with clinical signs, they look like Leishmaniasis. You see this, for instance, these ears with these lesions, these necrosis with ulcers and cross. The dog has lymphadenopathy, some weight loss, but when I do the serology, it's a low titer. It's borderline. In the immunofluorescence, 140. It's not negative, but it's not a clear positive, so I'm hesitating. It could be a dog with Leishmaniasis, and that these lesions that we see are consequence of the Leishmania infection, but it also could be that the dog is infected with Leishmania and the lesions are related to any other condition, immune-mediated disease, another infection. So I'm not sure that the Leishmania is the origin of these lesions, of these necrotic lesions, of these severe inflammatory lesions. What can I do? So in most of the cases, what we try to do with these seronegative or low positive dogs with clinical signs is to investigate the lesions to see if in the, let's say, inflamed skin or in the inflamed lymph node, we see parasites. So we try to identify a mastigotes of Leishmania associated with the lesions, because in this case, we know that these inflammatory and necrotic lesions are the consequence of the parasite, and that will begin the treatment. And for this purpose, it's PCR or immunohistochemistry are very useful. So what I'm going to do is I will take a biopsy. I will, in this case, a skin biopsy, as you see here. I will investigate this inflammatory infiltrate. You see mononuclear inflammatory infiltrate around hair follicles. And I want to know if in this inflammation we have parasites. And I can do this using immunohistochemistry, and you see here the beautiful Leishmanias stained in brown, or I can do a PCR. And if I see that there are, if there is DNA of Leishmania in this skin biopsy, then I know for sure that the cause is Leishmania. And if it's negative, no mastigotes in the immunohistochemistry, PCR negative, then probably the lesion has another origin. It can be another type of granulomatous inflammation, another microorganism. It can be a sterile pyogranulomatous condition, and maybe even I need to use steroids to control that. So for this purpose, molecular techniques are useful. I'm also using molecular techniques in the diagnosis of some dogs that are vaccinated and develop clinical signs of Leishmaniasis. You know that we have 2 vaccines now in Europe and in many European countries, including Greece. And one of them, the Canine Leishmaniasis vaccine, produces antibodies that can be detected with a serological test. And as the vaccine is not 100% protective, we see sometimes cases of Leishmaniasis or suspected Leishmaniasis in a dog that has been vaccinated. And it's difficult to use serology in this patient because the positive titer can be consequence simply of the vaccination. So what can I do? Well, real-time PCR can help us in this situation, among other techniques. Let's look at this example. This is a 2-year-old boxer, was vaccinated against Leishmania with Canine Leish 9 months ago. The dog is healthy. It doesn't show many systemic signs, but has developed these nodules, crusted, inflamed, on the ventral pinna, both pinna, these crusted nodules. No pruritus, no pain, happy dog, except for these lesions. When you see this dog, the differential diagnosis will be living in Barcelona, Leishmaniasis. In this case, will be a failure of the vaccine because the dog is vaccinated. But it could also be what we call a canine lymphoid granuloma, that in fact is a mycobacterial infection. It could be a sterile pyogranuloma syndrome. It could even be a neoplasia. So we need to do some diagnostic work to clarify the situation. And here you have the results. The serology in this dog was 44%, so a weak positive. That's again a problem. This could be simply consequence of the vaccine, or could be that the dog is developing an infection with Leishmania despite being vaccinated. So there's a mild increase in beta globulin, so not a very typical serum protein electrophoresis of Leishmania. And other parts of the CBC, serum chemistry, always within normal limits, and the cytology, the aspiration, shows only granulomatous inflammation. So what can I do to clarify if it's really Leishmaniasis in a dog that has been vaccinated or is one of the other conditions? Simply what they have to do is to do a biopsy and again try to investigate if in the lesions we have parasites. Of course, there are other ways to distinguish Leishmaniasis in a vaccinated dog or different disease in a vaccinated dog. There is a test called speed Leish that it's positive basically or only in dogs that have Leishmaniasis and not in simply vaccinated dogs without the natural infection. In some cases, you can use the real-time PCR to see a difference. Leishmaniasis usually gives you a big, high parasite load. If it's another condition and the dog was positive because of the vaccine, the PCR should be negative. And also, as I mentioned, probably the histopathology with immunohistochemistry and PCR is the most effective way to solve this condition. So coming back to the flow chart, we begin with quantitative serology, and we know that we solve many problems with this. But if the titer is negative and we still think that this could be a case of Leishmaniasis, or the titer is low, we continue our investigation, and in this case we do cytology, histology, and together with this we can use immunohistochemistry or PCR on the tissue to confirm or rule out Leishmaniasis. Finally, we also use the molecular techniques for the specific identification of the Leishmania species. We can use the PCR to be sure that the amastigos that we are seeing in the tissue or in the bone marrow or the lymph nodes are of Leishmania infectum, because all species look more or less the same. We are using the PCR also to detect genes associated with virulence or with resistance. And we know that, for instance, there are genes coding for resistance against miltefosine, and we are beginning to use the molecular techniques not for a diagnosis, but to understand better the type of infection that we have for using one treatment or the other to control this infection. Okay, so I gave you an overview or different situations where we can use PCR, and not as a first tool to make a diagnosis, but to detect infection in epidemiological studies, to investigate very special cases or complicated cases, or to identify the species very precisely or some molecular characteristics of this infection.
Okay, thank you. I think that, well, your explanation can help all vets to see which is the best technique and how to manage PCR and a serology test. But one thing that surprised me in your last slide is that you said that there are different Leishmania species. So I thought that at least in Europe, Leishmania infantum was the only one that was present, but it seems that it's not like that exactly. So do you have more details about that, or which is the situation nowadays?
That's a very good question. Yes, in general, most cases of Leishmaniasis that we see in dogs in Europe are caused by Leishmania infantum. But there are at least 6 species of Leishmania. There are many species of Leishmania infecting mammals, more than 40. But 6 at least has been shown to cause clinical Leishmaniasis in the dog. And 3 have been detected in Europe. One is Leishmania infantum, the other one is Leishmania major, and the third one is Leishmania tropical. These two are more typical of north of Africa, but they have been detected in dogs in some parts of the Mediterranean. For instance, Leishmania major has been reported in several cases in Saudi Arabia, in Egypt, Israel. Recently, Gad Banner presented a couple of cases of infection with Leishmania major. And the appearance, the microscopic appearance of the parasite is identical to Leishmania infantum, and you need to use, in this case, PCR amplification to be sure that this is a different species. Of course, the clinical picture is not so typical, but this ulcer on the skin, it's something that we see also with Leishmania infantum. So if you suspect that maybe it's another species because the dog has been living north of Africa or in Middle East, probably you need to do a PCR to double check that the organism is Leishmania major. And the same for Leishmania tropica. Leishmania tropica has been detected in dogs in Morocco mainly, but also Gad Banner presented a case recently of an ulcer on the nose of a dog. Probably tropica is less pathogenic, less virulent than major, and much less than infantum in the dog, but we can see cases, and I'm sure that if my colleague will see an image like this one, with macrophages loaded with mastigotes, they will say this is Leishmania infantum. But if you, and even these dogs are seropositive for the classic serology for Leishmania infantum, but if you do a PCR and you identify the sequence of the DNA, you will confirm that in fact it's Leishmania tropica. So yes, there are other species, but it's something very, very rare, unless the dog has been living in some parts of the south of the Mediterranean.
Okay, then, well, it seems interesting, and that we have to learn about how is maybe changing the prevalence of these different species. And now I think that we have been talking about diagnostic, but I think that it's maybe interesting to move to the treatment, because after the arrival of new drugs, the whole world recommends a combination with antimonials or maltiphysin with a long-term allopurinol. But I would like to ask you, what's your opinion, what's your experience with that treatments?
Yes, I think that now there is a big, let's say, agreement that the best treatment for most cases of canine leishmaniasis, what we call stages 2 and 3, that are clinical cases of leishmaniasis, is the combination of antimonials, meglumine antimoniate or glucantime, and allopurinol. And we recommend to use the antimonials for 4 to 6 weeks, at least those, and at the same time to begin a treatment with allopurinol twice daily, between 5 to 10 milligrams for at least 6 months, and the combination of two drugs. And there are many papers. One has been published by Manolis Mikelakis. It's a big, huge dermatologist from Greece, and there is a big consensus that this is clearly the best treatment for leishmaniasis. It's true that there are many controversies regarding the use of antimonials. I'm not going to go over all this because it's pretty late, but in fact, this treatment has been shown to be pretty safe. Even the suspected nephrotoxicity is not a big issue. There are very few cases of nephrotoxicity, and the practice, the daily practice shows that even the renal damage improves when you begin a good treatment like this one. And it's true that we suspect that maybe some dogs develop resistance, but there are not many data regarding that in the dog. And if you follow this treatment, this protocol, as you can see, we use only for a short period of time the antimonials at the beginning of the treatment, and we also use it together with an allopurinol, so we do not use monotherapy to prevent resistances. So I think at this time, this is the best way to treat the condition. It's true that there is an alternative. There's the use of miltefosine, as you said, together with allopurinol. And it's true that this is my second choice. When the first treatment doesn't work, I move to that one. But now we have good studies showing that the combination of antimonial with allopurinol is better than the combination of miltefosine with allopurinol. It's faster, and here you have a paper that showed that, and the clinical improvement is more rapid and more consistent with the combination of antimonials. So this is my preference.
Thanks, Lluís. Now we have a better idea about the treatment. However, it seems that there are some differences related with the duration of allopurinol. I don't know if you can give us a little bit explanation about how much time maybe we have to use the allopurinol.
Well, it's true that there are many differences in the way that people use allopurinol for the treatment of Leishmaniasis. I say that nowadays most people use a combination of antimonials and allopurinol as a main line of treatment. There is more difference in the way that people use the allopurinol, and there are many questions regarding for how long I have to maintain the treatment with allopurinol. In my slide, you have seen 6 months, but some people say 1 year, some others say 2 years, some others lifelong. So there are more differences regarding that. Let me make a few comments about allopurinol because I think it's very interesting. Allopurinol is an excellent drug. So we have had much better results when we have begun to use allopurinol in all cases of Leishmaniasis. So it's not a secondary treatment. It's very important. It's also, some people say that it's parasitostatic, also has a parasiticidal effect, and is highly effective controlling canine Leishmaniasis. It's synergic with the meglumine antimoniate. It's very well absorbed and has a half-life of about 4 hours and a renal clearance. So it's a very good drug for the treatment. My recommendation is to use it between 5 to 10 milligrams, meaning that in large dogs, I go for a dose closer to 5. In small dogs, I tend to use it close to 10 milligrams per kg every 12 hours, a minimum of 6 months, between 6 and 12 months. At that time, I check the patient, I do some urinalysis, and if everything is okay, I usually continue for 1 year. If I start to see xanthine, crystals or urolithiasis, then I reduce the dose and I consider stopping the treatment. It's important also that we know that allopurinol has some important drug interactions, mainly with azathioprine and also with cyclosporine, increases the levels of serum levels of cyclosporine, and side effects. In humans, it's well known that it can cause GI upset. Cutaneous adverse reactions are very common in humans. They say that more than 1% of patients taking everyday allopurinol to prevent urolithiasis and other conditions, they develop severe cutaneous adverse reactions. And we see that occasionally. Some dogs on allopurinol develop this type of exfoliative dermatitis. We know that. That's something that we see. And when you discontinue the allopurinol, the skin lesions disappear. But the main problem that we have with allopurinol is urolithiasis. And that's very important. And this urolithiasis is a consequence of hyperxanthinuria, leading to the formation of complex uroliths, of ammonium urate covered with xanthine. And it's especially important in some dogs that are genetically predisposed. So what I recommend is to use an adequate diet, low in purines. Be sure that the dog has also water supply and do periodic urinalysis. And I limit the duration of the treatment or reduce the dose according to the results of the urinalysis. But yeah, it's true that there is more variation on the recommendation, and some people use this for 1 year, some others for 2 years, some others begin with 5 milligrams. There is less evidence regarding the dose of allopurinol.
Yeah, so well, you talk about the diet, the role of diet in controlling the disease. So sometimes you know that we work with diet. So sometimes we receive some questions from our colleagues, from our vets, asking us which diet is the best one to use when we have a dog with leishmaniosis. And the main issue that we face in the field is the doubt if to use a renal diet or a low in purine diet. So if you can explain a little bit more about that, I think that will be really helpful for the vets.
Yeah, dietary management is very important in leishmaniasis. So I always insist to my clients, the tutors of dogs with leishmaniasis, that it's very important to control other infections, to control other parasites, to make a good preventative medicine, and also to give a good food to the dogs. There are many studies showing that the diet has a big impact on the infection and on the progression of the infection. So patients with leishmaniasis should receive a top quality diet, high in quality protein, high in essential fatty acid to reduce inflammation. So they need very good food. And also, there are two different situations. In most of the cases, a dog that is seropositive, stage 1, stage 2, stage 3, so different types of severity of the condition, I recommend to you, and if the dog is on allopurinol, like most are, I recommend a diet low in purines. There's one that's called Leishmaniasis management. There are some others that are called low purine. This is the adequate diet for these dogs. They have low purines. We reduce the risk of developing urolithiasis, and we can maintain longer the treatment with allopurinol, and we control better the infection. Only if the dog has severe kidney disease, kidney failure, then we go to the renal diets that are usually low, a little bit lower in protein, they are low in phosphate. So only in the case that we are facing a dog in stage 4 or with renal disease. In all of the cases, we simply go for top, good protein with low purines.
Thanks, Luis. I think that it's quite clear. The next question I have is that in last years, we have reading or listening in a lot of conferences the use of immunostimulants to the treatment of leishmaniosis. So I would like to ask you, when do you think that they will be a normal part of the treatment of that disease?
That's a good question. It's true that immunostimulants will play a big role in the control of leishmaniasis. Now, we are still already using some of them, and especially in the future. And there are different types of immunotherapies, and there are some called non-specific immune potentiating drugs, like domperidone, that we use in dogs with stage 1 that are infected but do not have clinical signs. And we also use domperidone for preventing relapses in dogs that have been treated. There are some other non-specific immunostimulants, for instance, the combination of nucleotides and exos. At least in some European countries, there is one product called Impromune that it's effective stimulating the immune system, and has been shown that it helps to control the infection with Leishmania. Now there is a clinical trial currently running to demonstrate that this treatment is effective to prevent relapses of Leishmaniasis. And now there is a big research area regarding the toll-like receptor agonist, some drugs that stimulate the innate immunity, the toll-like receptors. And there are some recent papers showing that this could be a very good treatment in the future. And also, we are beginning to think that vaccines can be used also to treat Leishmaniasis, not only to prevent the development of the clinical signs, but also to treat those that are already infected or even sick with clinical signs, because the vaccine, they do not contain the infective agent, they contain only proteins of the parasites. So they stimulate the immune response. So I think that this will be something that we will see in the near future. For instance, some groups in Spain are working with this product, Impromune, that are nucleotides in combination with allopurinol to reduce the frequency of relapses. So we are following the classic diagnostic protocol with glucantime, antimonials, and allopurinol. But when we stop the glucantime, we begin the immunostimulant. It's better to use this when you finish the antimonials, because the parasite load is low and the immune system is recovering. This is a good time to begin an immunostimulant and see if combining this with allopurinol, that are two very safe products that do not create resistance, we can prevent the development of new relapses of the condition. And also there is a lot of interest assessing if vaccine can be used in sick dogs. There is this good paper done in Brazil in 2018 showing that if you vaccinate infected animals that are still healthy, so they are positive for the PCR for the parasite, but they do not have clinical signs, then you vaccinate these dogs, they can help to prevent the development of clinical signs. And now there is at least one clinical trial to assess if letifen vaccine in seropositive dog can prevent the development of clinical signs. So we will see in the coming years many more examples of the use of immunostimulant drugs to help the control of the disease.
Okay. Thanks, Luis. I think that well, it's quite interesting to see that new drugs or new treatments are arriving and new options to treat the dogs with this disease. And just to finish the webinar, I have my last question, because you have been talking several times about vaccination, and we know that when we are in the field, that some vets like the vaccination against Leishmaniosis, but there are other ones that they don't want to vaccine the dogs. So I don't know if you can share with us your experience or your preference maybe, and what have you seen about vaccination?
Yeah, I think I'm in favor of using vaccines. So clearly, of course, for many infectious diseases, but also for Leishmaniasis. But probably we need to understand better how vaccines work and in which cases they are especially indicated. So before focusing on vaccination, remember that we have now two strategies for prevention of canine Leishmaniasis. One is the group of interventions to prevent the infection of the dog, and basically is the use of topical insecticides or repellent insecticides. So this intervention prevents the dog becoming infected. And then we have another strategy to prevent the disease, that is to stop the progression of the infection to clinical disease. And we can use vaccines, we can use some immunostimulants. We have now on the market domperidone. So there are two different types of prevention for the disease. In the first case, what we do is to use basically pyrethroids, and that have repellent activity against the sandflies, and they have insecticidal activity. They kill by contact and by ingestion the sandflies when they go to suck blood of the dog, to bite the dog. So this strategy, the use of topical insecticides, has been shown to be very effective. There are many papers, they have very good top quality evidence that they prevent the infection. This has been done in laboratory studies showing that these insecticides, they have repellency and they have insecticidal effect. And also we have many field studies that have demonstrated that if you use these collars or spot-ons in a big area, there is a marked reduction of infection in dogs. So there's no doubt that this is an effective and safe strategy. So my recommendation will be all dogs living in endemic areas, and even in the areas close to endemic areas, should be protected year-round with one effective topical insecticide. The objective should be to have 100% of the dog protected, as we have done for other parasites like filaria. Filariasis has been eradicated in some areas because of the constant treatment of the dog. Of course, you can use in some cases a collar, you can recommend a spontan, in other cases depending on the dog. But I think that we have to, our goal is to have all our dogs protected. Because I'm worried about that, last year I did, with one of my last year students, we did a cross-sectional study about the use of these preventative measures against Leishmaniasis in our clients. So we are a big, let's say, hospital, a reference hospital. When we receive cases from other parts of Barcelona and Catalonia, we have people that are really motivated to go to the vet, that they take care of the dogs. And we have been, along the year, making polls and asking to all the clients, are you using any prevention against canine leishmaniasis? And surprisingly, in a very selected population of clients that they love the dogs, they go to a specialty hospital, and only about 80% use active measures of protection. So still 20%, because of different reasons, lack of compliance, yeah, I should, but I forgot. I thought that I have to use it only a few months of the years. I don't like to use chemicals on the dog. There are different reasons they don't do that. So there is a big room to improve, because this is not a sample of the population of dogs living in Barcelona. This is a very selected group of dogs. If you go to any village and you ask the first dog that you see, probably instead of 80%, you will find 50% or 60%. So I think that our goal as vets is to insist first to have all dogs covered with that. And also dogs visiting endemic areas, they should be protected with effective insecticides for the entire period traveling. They don't need to be vaccinated. If they go from Sweden to Greece for 2 weeks, they don't need to be vaccinated. They simply need to be well protected. And if they want, 4 or 6 months after coming back to North Europe, they can be evaluated with a quantitative serology. So the second strategy is the use of, let's say, prevent the development of the disease, not to prevent the infection using vaccines or domperidone. In this case, we know that dogs vaccinated can become infected. The vaccine do not protect. The vaccines do not protect against the infection. They simply prevent the progression from infection to clinical disease or reduce the severity of the disease. So far, 3 vaccines has been marketed, one in Brazil, which is the Leishmaniasis vaccine, and 2 in Europe, Canine Leishmaniosis and and also domperidone has shown to be immunostimulant preventing the progression of clinical signs in Leishmaniasis. How are these vaccines? They're good. They have an efficacy in all 3 cases around 70%. It's a little bit lower than the insecticide repellent, but it's good. And they are helpful reducing the risk of developing clinical signs. And there is big discussion among the veterinarians against recommending or not vaccination against Leishmaniasis. I know that some colleagues say, no, I do not recommend that because they have low efficacy compared with distemper vaccine or rabies vaccine. There are not many phase 4 clinical trials, so post-market studies showing that really the dogs that have been vaccinated are protected, apart from the studies, so studies done with the vaccine on the market. They can cause interference with serological diagnosis. We've been talking about that. So you can have a positive dog and you don't know if it's because of the vaccine or because it's developing the disease. In some cases, they have side effects. They mainly cause nodules on the inoculation site and pain, and they are expensive also. One of them has to be inoculated 3 times. I see more the bright side of the vaccines. There is clearly a reduction of the risk to develop clinical leishmaniasis. This has been shown in the 3 cases. They are not 100% effective, we know that, but we know that if you vaccinate your dog, there's less likelihood to develop the disease. They are synergic with or add protection when used together with the insecticide. So you do 2 different things to protect your dog. You prevent infection with the insecticide, and in case that the insecticide fail, then the progression to the disease is also less likely or less severe because you vaccinate the dog. And probably there are some papers showing that also they can help to reduce the infectiousness to sandflies because there is less clinical disease. So we need to know more about that, about the impact of vaccine on the spreading of the condition, but it's a very encouraging to think that if there is less clinical signs, there's less parasite available to the sandfly. So in general, my recommendation is in endemic areas, you can vaccinate your dog on top of using insecticides. Do not choose between one of these 2. If you have to use one, use insecticide. All dogs should be protected with insecticide repellent. If you want to do more, then vaccinate your dog. It's safe, it can help, especially if it's a young dog living in an area of high infection, or if your dog belongs to one of the breeds that we know are predisposed, like German Shepherds, Boxers, Rottweilers. If your dog is living outdoor, in this situation, why not to add the protection of the vaccine to this patient? And if a dog is seropositive, we know that we cannot vaccinate these dogs until now, so probably in the future this will change, but you can use domperidone to reinforce the immune response, and again, you can use that on top of using the insecticide. This will be my recommendation, Alba. And I think that I answered your last question. Now I think it's a turn of the audience. If they have questions, I will be more than happy to answer them.
Yes, thanks, Lluís. Thanks to share with us all your knowledge. I think that in this session, we have learned a lot. So yes, now it's the turn for questions. I have seen that several vets have written their questions during the conference. So now we start with the first one. I would like to ask you to give us a like, because it's quite important for the Vets and Clinics channel. So Lluís, we have 3 questions from our audience. So I will start with the first one. It comes from Romania. And the question is that there, in that country, vets are using rapid tests, so usual. So can you explain us how accurate they are, and if these rapid tests, they are a good option to diagnose leishmaniasis?
Yeah. These rapid tests detect the presence of antibodies in the serum or in the blood of the patient, and they are quite accurate. They are good for screening, especially in an area where leishmaniosis is not very common, where you are using the test simply to rule out that the dog is not a case of leishmania. If it's positive, then probably you need to do a quantitative serology, because you need, as we mentioned before, you need to know the titer of antibodies, because we know that if the titer is really high, the likelihood of a severe condition or disease is higher. So the test can be used for a first screening, but not for managing a case. Also, we will need the titer at the beginning of the treatment for monitoring along the coming months or years of these patients. So they are good as a main screening test, but not as a definitive test. Also, if the test is negative and you still suspect that this can be a case of leishmaniasis because the clinical the signs are very typical, please do a serological quantitative test, because some of these tests are not enough sensitive and borderline cases are considered negative, although they are cases of leishmaniasis.
Okay, thank you, Lluís. We have another question about the treatment. And the question is that if the glucocorticoids are always contraindicated when we are treating leishmaniosis. What do you think?
That's also a good question. In general, yes, we do not recommend the use of glucocorticoids because they can affect the immune response that we know is essential for controlling the infection. But we also know that in some cases, the lesions that appear in patients with leishmaniasis are consequence of the immune reaction. For instance, in some cases, uveitis or glomerulonephritis and proteinuria, or arthritis, or in some cases, some pustular reactions in the skin. In these specific cases, we sometimes use glucocorticoids topically, for instance, in the eye, or at low anti-inflammatory doses to control these lesions associated with the immune response to the parasite.
Many thanks, Lluís. I think that it's quite clear now. And the last question, leishmaniosis is more prevalent in dogs. We are talking always for dogs. But now if we move to the cats, how prevalent is the leishmaniosis in cats? If it's quite prevalent, which is the best treatment for these animals, these cats that they are diagnosed by leishmaniosis?
Yeah, interesting. We always think that leishmaniasis is a disease of dogs and humans and not a feline disease. But it's true that recently we see more and more cases of leishmaniasis in cats in endemic areas in all the Mediterranean. And we know that it's probably a bit more frequent than we thought. And probably we missed some cases because we never considered in our differential diagnosis Leishmaniasis in cats. And in our hospital, we see every year a few cases of Leishmaniasis in cats. Cats get infected with Leishmania. In most cases, they are able to control and eliminate the infection. But a few cats, especially immune suppressed, or cats with neoplasia, can develop the disease. Clinical signs of the disease, usually skin nodules or chronic ulcers, in many cases on the face, around the eyes, lymphadenopathy, and they develop a progressive disease. There are not many, but we see cases of cats. If you run an epidemiological study in cats in one endemic area, you will see that there are a few cats that are positive in serology. They are seropositive. Less than dogs, but there are few always, meaning that the cats are infected, but most of them are able to control the infection. When you have a case of feline leishmaniasis, usually if it's a mild case, veterinarians usually recommend the use of allopurinol only at 10 milligrams twice daily, or 10 to 15. If it's a more severe case, then we combine allopurinol with antimonials like in the dog. And then as we have less evidence and data about this treatment in cats, we used to monitorize these cats more frequently than dogs to be able to detect early side effects or damage caused by the treatment. But yes, we see cases of feline leishmaniasis, and this is an emerging disease in cats. Thank you, Alba.
Thank you, Lluís. Well, I think that we are at the end of this webinar. So first of all, thank you, Lluís, to be here with us and share with us your knowledge. And for all the vets that are connected, I invite you to subscribe to our Vets and Clinics website. You will see there a link to subscribe. And in that way, you will keep informed about next webinars. We are planning new sessions for the next month. So I hope you have enjoyed that, and I hope to see you soon. Thank you very much.